you are able to stay healthy and safe at home. Due to the evolving situation around the COVID-19 outbreak, we're taking every precaution to look after our Parkinson's community. In our efforts to help you stay connected, the Parkinson's Foundation is providing weekly educational and wellness programs in a virtual format through our PD Health at Home series. Each Monday at 1 p.m. Eastern Standard Time, we will have a live expert sharing their tips and knowledge on staying mindful during this unique time. Every week, we will explore a different topic of how the practice of mindfulness can influence your health and well-being. The Parkinson's Foundation is dedicated to engaging and empowering the Parkinson's community. I am thrilled to be able to share this time during our Mindfulness Monday event with you. Mark your calendars and join us next Monday as we dive deeper into the practice of mindfulness and its benefits as we cope with the challenges of physical distancing. To learn more and to register for individual events, visit parkinson.org/PD Health. This is new for all of us, so we thank you in advance for your patience while we are getting used to doing things a new way. As a reminder, your questions can be submitted through the chat function in the black banner on the bottom of your viewing page. We will do our best to answer as many of your questions related to mindfulness as we can during the Q&A portion of this program. Today's session will be recorded and archived on our website at parkinson.org/PD Health. Before I introduce today's speaker, I'd like to tell you a little bit about the Parkinson's Foundation mission and resources. The Parkinson's Foundation makes life better for people living with Parkinson's disease by improving care and advancing research toward a cure. In everything we do, we build on the energy, experience, and passion of our global Parkinson's community. We provide families with free resources, including our website, parkinson.org, educational books, webinars, podcasts, a hospitalization kit, and our bilingual toll-free helpline, 1-800-4-PD-INFO, which is staffed by Parkinson's specialists. To learn more about our resources and our upcoming virtual events, remember to visit our website at parkinson.org or call our helpline at 1-800-4-PD-INFO. Now it's my pleasure to introduce and welcome our guest speakers, Dr. Hiller. Dr. Amie Hiller is a movement disorders neurologist working at Oregon Health and Sciences University, a Parkinson's Foundation Center of Excellence, and VA Portland healthcare system. Dr. Hiller completed her MD at the Medical College of Georgia, her neurology residency at Brown University, and health policy fellowship in Washington, D.C., and a movement disorders fellowship at UMass Medical Center and OHSU Portland, VA. She has had an interest in mindfulness and Parkinson's disease since her time at UMass and completed a pilot study with Dr. Proulx on this topic. Also joining us today is Dr. Jeffrey Proulx. Dr. Proulx is an assistant professor of public health and medicine at Brown University. He is also a senior researcher at the Mindfulness Center at Brown and an affiliate assistant professor in neurology at Oregon Health and Science University. Dr. Proulx is a developmental health psychologist, and his work explores how the brain and body are related, particularly in regard to health effects associated with psychological stress. Dr. Proulx is formally trained as a mindfulness-based stress reduction teacher and has explored the application of mind-body interventions in Parkinson's patients. I would now like to introduce and welcome our speakers, Dr. Hiller and Dr. Proulx. Dr. Proulx, you'll be kicking us off.
And hi, good afternoon, good evening, good morning, everybody, depending on where you are. And as we like to do for just a few moments is to arrive and to just take this moment to center ourselves and to become more present. So all I ask you to do is just think about your posture, relax in your body, have a nice straight spine. coming to a position that exemplifies being awake and being dignified. Letting go of whatever we were doing before we met here, and letting go of whatever we may be doing later, and just centering in on your breath right now. Just gently watching the tidal rhythms of your breath, breath coming in and breath going out. And if you just sit patiently, just like a snow globe that's been shaken up, if you just sit, everything will just settle. And just opening your eyes if they were closed and wiggling your fingers and toes, and prepare to hear from Dr. Hiller.
Good morning, or afternoon, or evening. My name is Dr. Amie Hiller, and today I'm going to talk about sleep and problems that sleep that we can see in Parkinson's disease. And then we'll talk a little bit about how mindfulness may be helpful in Parkinson's for sleep issues, and specifically we'll focus on doing a body scan. So next slide. So we wanted to start with just asking everyone here if your sleep is as good as you'd like. Wow, okay. So it looks like no. I can also tick myself in the no box there. I have 2 young children, so that tends to be my main limitation with sleep. So it looks like about 25% of people are doing fairly well, but about 80% not doing as well as they'd like. So I'm glad that everyone is here, and hopefully we can offer some suggestions with things today. Next slide. The next question is, do your sleep issues affect your bed partner? You might need to hand the computer screen here over to the other person who's with you. So a little less here, and some people may not have bed partners, or even if they have a significant other, may choose to sleep in separate places. So a little over 50% doesn't seem to affect their bed partner. About 45% do. I'm not sure who's answering this. So again, maybe if the bed partners answered it, we'd see a little bit higher numbers. And we'll talk a little bit about how sleep can affect others too. So in terms of the sleep problems that we see in Parkinson's, they're extremely common. And this is a list of the kind of big ones that come to mind. So nighttime urination, which I'm not going to go a lot into here, but that is a very common problem that we see. Almost 70% of people restless leg syndrome, insomnia. This is one of the things that I'll talk quite a bit about today. Vivid dreaming, sleep talking or moving, and then daytime sleepiness, which is another one of the areas I'll focus on today. And these aren't exclusive, so you can have more than one of these, and many people do. Next slide. So another question we wanted to ask is if this is something that you've talked to your provider about. So your neurologist is kind of the main one I would think of, but someone else. Have you talked with them about poor sleep or daytime fatigue? So it looks like a good chunk of people have reached out to their providers, which is good to hear. So a little over 60%. I think sometimes it is something that's a little difficult to bring up. And again, this may give you today some ideas of what things to focus on when you bring it up with your provider, hopefully. Next slide. So just to give you an overview about what we're going to focus on, again, there's more sleep problems than this, but with kind of a short lecture and also putting the mindfulness piece in, it's not possible to go through everything. But I'm going to talk about insomnia and why that happens in Parkinson's, a daytime sleepiness and why that happens, and then how mindfulness might be helpful. And then we'll do a body scan, which is a mindfulness practice. This will be a little longer practice than we've done in weeks past. But I think is a really lovely one, and also something that can be helpful for getting to sleep. And then we'll have some time for question and answers. Next slide. So insomnia, daytime sleepiness, and sleep attacks. These are some little cartoons here. We've got the person who's sleeping all the time and the person who is exhausted but can't fall asleep. And then our chronic fatigue syndrome anonymous, where everyone's asleep at the meeting. Next slide. Next slide, please. Thanks. So the areas of the brain involved in sleep. This is not a slide to try to look at and understand or memorize all these complicated Latin names. It's simply to show that there's a lot of the brain that's involved in sleep. This is a pretty complicated system, involves a huge portion of our brain. When you think about how much of our life should be spent sleeping, this kind of makes sense. The other piece, you'll notice there's a pink circle there, and I've kind of used pink as my color to show Parkinson's specific things, is the cell loss in these areas. So in most of these areas, ballpark 20 to 50, 60% of loss of cells in people with Parkinson's. So it makes sense that there's a lot of sleep issues in Parkinson's. It also makes sense that the sleep issues aren't the same for everyone, because there may be in one individual a little bit more lost in one spot and somebody a little bit more lost in another. And as anyone who has spent much time working or interacting with people with Parkinson's, I expect you all have, you'll know that it's not the same disease in everyone. In neurology and movement disorders, we have a saying, if you've seen one case of Parkinson's, you've seen one case of Parkinson's, because the disease is very different for different people. So figuring out what's going on with sleep involves a lot of discussion and then targeting for the individual and trying to get things better. Next slide. So insomnia. So insomnia is trouble with sleep. That's the general term. And we can categorize it into different kinds of insomnia. So there's trouble to getting asleep at the beginning of the night, called sleep initiation. And this can happen in Parkinson's, but usually isn't the primary problem. There's trouble staying asleep. And I'll talk a little bit more about this because this is the one we see most often in Parkinson's. And then there's trouble with early mornings awakenings. So looking at these, the sleep initiation is the one where sleeping pills tend to be the most effective. That really tends to be what they can help with. The other issues, sleeping pills don't tend to work so well, because whenever we use a chemical to help us sleep, for the most part, it really helps us get to sleep. But if we give people enough of it to keep them asleep all night or to keep them asleep in the early morning hours, they're often going to feel really groggy then and not feel great during the day. So again, I'll talk a little bit more about medications, but the medications usually are most effective for that sleep initiation piece which generally in Parkinson's is not the big problem. Next slide. So as I said, in Parkinson's, the most common problem is trouble staying asleep. So the classic I'll hear from people is, I fall asleep okay. Actually, I oftentimes fall asleep earlier than I want. I'm sitting in front of my, television in the evening, and I start to doze off. And then I go to bed, maybe trouble falling asleep when they make that transition from the chair to the bed, or they go sleep okay in the bed, and then they wake up at midnight or 2 o'clock in the morning and then have trouble going back to sleep. And these are known as sleep maintenance problems, or also known as sleep fragmentation. And there's a number of reasons why this happens in Parkinson's, and we'll talk a little bit more about that. Next slide. So if you look at the red line here, this shows what normally happens in terms of our sleep urge. And this slide is a little confusing, or the diagram's a little confusing in that it starts at midnight. So kind of when the new day starts. But our sleep urge should be very high at midnight. And then it should reduce as we go into the morning. So maybe we still feel a little sleepy when we actually wake up around 7, 8 a.m., depending on what your schedule is like. And then the morning should come and we should really start to feel pretty awake. And then we have that little bump in the afternoon, that siesta time in many societies, or our post-lunch, you have that lunch and then you're ready to zonk a little bit after that. And then another dip in the evening, and then a rise as we get into the later evening. So that's what our sleep urge should look like. Our sleep need, again, starting on the left side of the slide at midnight, we're sleeping. So our need for sleep goes down as we sleep longer. And then throughout the day, our sleep need should go up the entire day. That may change a little bit if we're napping, but really it should go up. And then once we start sleeping, then that sleep need goes down. In Parkinson's disease, the sleep urge through those wee hours, so from midnight, 2 a.m., is generally reduced. So the urge to sleep is not as strong as it is in people without Parkinson's oftentimes. So this is why we see some of those early awakenings. And then we'll talk a little bit later about other things. And there are multiple causes of why, actually, can you go back to the previous slide? I'll just spend another moment on here. And this is the circadian rhythm that people have probably heard about, that our body kind of goes through this pattern each day. Okay, next slide. So there are multiple causes of insomnia. So aging, we know that aging just changes how our sleep is. We're not as good at sleeping as we age for the most part. When we do sleep, it's not as good of sleep. And that degeneration that we see in those cells in Parkinson's, we see overall degeneration as people age. So that's expected. People can have vivid dreams that wake them up. So if you have that's quite common in Parkinson's, you have a very vivid dream, you wake up, you feel like you've just been in this crazy environment. It seems totally real. It's probably not going to be real easy to fall asleep after that if you've been really in this strange other world that seems like you're actually experiencing it. Depression and anxiety can be a big one. So people who are depressed sometimes don't have a lot of energy to get up and go during the day, and then as nighttime comes, they're not as fatigued as they should be because they didn't get kind of enough energy out during the day. Anxiety is a super common one. So there's actually parts of our brain, the deeper structures that have more to do with our fight or flight response are more active overnight, and our thinking part of the brain that kind of helps calm those things is less active. So it's very common to wake up in the middle of the night. Maybe you get up to go to the bathroom, but then you come back and you're like, oh my gosh, I have this to do and that to do and this to do. And these fairly minor things may seem like they're just huge issues. Even if anxiety is not a big issue for you in the middle of the night, things can seem very anxiety provoking that wouldn't at other times. And this is normal. So mindfulness is actually a good technique to help to reduce that anxiety potentially that you're experiencing overnight. Frequent napping can sometimes be a cause of insomnia. I'll talk a little bit more about napping because I feel like in Parkinson's, sometimes napping actually is helpful. In other disorders, they often say not to try not to nap. But if you're frequently napping, I have patients sometimes who I'll go through their sleep routine and it ends up they're napping 2 to 4 hours a day, and then they're upset that they can't get 8 hours of sleep at night. And if you're getting 2 to 4 hours of sleep in naps, then you shouldn't need 8 hours of sleep at night. You should actually need, 2 or 4 hours less a night if you're getting a good nap during the day. Nighttime urination, which, like I said, I wasn't going to go into detail on, but that's a very common reason why people are up through the night. And then sleep apnea is another one. So sleep disordered breathing, which can often be treated with the CPAP, sometimes some other devices. Next slide. This is another slide about the causes because there's so many, I couldn't fit it all in one slide. There's different neurochemistry changes in Parkinson's. So that slide I showed you with the areas in the brain and the cell loss, that means there's chemical changes as well that goes along with that cell loss. There can be trouble rolling over in bed. So we know throughout the night we're in deep stages of sleep, but then we're also in lighter stages of sleep, and we go back and forth through that throughout the night. And when you're in that lighter stage of sleep, it's very normal to have some movements. You might roll over just to get comfortable, but in someone with Parkinson's, that rolling over may be quite a bit more difficult, and then it may really awake them, and now they're awake rather than staying in that very light stage of sleep. The medications oftentimes wear off. So for most people with Parkinson's, their medications aren't lasting 8 hours. So it often wears off through the night. Restless leg syndrome is a feeling of uncomfortableness in the legs when they're still. That's often worse at night, and we can see that in Parkinson's. We can also see it in people without Parkinson's. The medications themselves can sometimes be stimulating for people. One that we really think about this way is amantadine. So if you take amantadine and you're having sleep issues, you probably shouldn't be taking it real close to bedtime. We usually recommend early afternoon, mid-afternoon is kind of the latest time for that. And then REM sleep behavior disorder, which is an acting out of dreams that can happen in Parkinson's especially, and that can wake people up and wake bed partners up as well. Next slide. So how do you manage insomnia? So if there's a clear cause that can be treated, this is ideal. So, but as we saw from the early on slide, there's often more than one thing going on, and there's not often a real easy treatment. So we'll talk about a few of the things kind of more Parkinson specific, but if you have sleep apnea, you want to try to get that treated. If you're getting up to urinate more than 2-3 times a night, it would be good to talk to your doctor about that. If turning off is the problem, so if it's that your medications are wearing off, an extended release medication at bedtime might be helpful. So there's extended release versions of the dopamine agonist, ropinirole, pramipexole, also known as Requip and Mirapex. There's also extended release versions of carbidopa, levodopa. So those might be options to try. Deep brain stimulation actually can be quite helpful for sleep. We generally don't do it just for sleep, but all the studies that have been done have shown that people get improved sleep. And this is likely because they're not getting into quite as deep and off overnight as they did before surgery. Next slide. Trying to have good sleep hygiene. So I assume many people have heard about sleep hygiene, and it's easier to talk about than to do much of the time. But you want to try to exercise during the day, so get that energy out. Like I mentioned, I have 2 young children, and we talk about getting your wiggles out during the day so that we can hopefully have peace at night and get everyone to sleep before the wee hours. But exercising during the day, but you don't want to do it right before bedtime. Exercise can be a bit stimulating, so especially if you're going to do something cardiovascular, to try to do it a bit earlier. Sometimes right after dinner is not a bad time, or right before dinner. I also like if people have a time of day when they tend to eat too much, it's often good to put exercise in there. So afternoon is a good time. I think a lot of times that's kind of that pre-dinner hour can sometimes be a snacky time, and that can be a good time to try to get your exercise in. Don't eat large meals right before bedtime. So you want to have dinner and then give yourself some time before you go to bed. Try to develop a relaxing routine. So not wanting to do vigorous exercise before bed, but it might be nice to do some gentle stretching. If you do yoga, doing some gentle yoga postures. Again, mindfulness could really come in here. Reading is often helpful for people. I'll talk a little bit more about television, but you don't really want television or bright screens close to bedtime. Trying to go to bed and get up about the same time every day. And this, it's hard to determine exactly when you go to sleep, but you can get to bed about the same time. And you can't always make yourself get up. So I think that's sometimes hard to do, but that's one that you can actually have some impact with. Avoiding caffeine, nicotine, and alcohol too close to bedtime. So what often happens with alcohol is people will initially fall asleep, but then they tend to wake up. So alcohol has these kind of interesting effects on our sleep that initially it'll help us fall asleep, but it often results in fragmented sleep. So the biggest problem with Parkinson's is worse there. Next slide. So like I was saying, doing something relaxing for bedtime. So a mindfulness practice might be nice. The body scan that we'll do today, I think could be a really nice one. And there's places where you can get those as well. And you could record one. I myself actually have a body scan meditation on my phone. It's the same one that I listen to all the time, and use it if I just have a time to rest on the weekends. And if I'm having trouble or wake up early in the morning, I'll often use that. Just some deep breathing can be helpful potentially as well. Ideally, you do not want to watch TV in the bedroom. So if you're able to have a television outside of the bedroom, that's great. What sleep people often say when they give these talks is they'll have people who go, well, I have a television in my bedroom and I sleep just fine. If you sleep just fine, don't worry about sleep hygiene. If your sleep is great, if you're that 20% in the beginning who said you're not having any problems, you don't need to do these things. You don't have to worry about it. But if your sleep's not good, then you do need to think about these things. And oftentimes the behavioral things that we do are going to work better and not have the side effects that other things we can do. So like I talked about in the last slide a little bit, you don't want to go to sleep hungry, but you also don't want to have a full stomach. So, if you have dinner and then it's a few hours later and you're about to go to bed and you're a little bit hungry, try a little snack, but don't have a big meal, something minor. Next slide. A soft pillow is often helpful for people. A firm mattress, too soft a mattress isn't always the best. Avoid hot showers in the evening, but you can take a lukewarm bath. So again, think about things that are going to relax you, but not stimulate you. So kind of thinking about those two things. Avoid fluids after around 7 if you have trouble with urinating overnight. If you don't have trouble with urinating overnight, don't worry about it. But, and if you're going to bed real late, obviously this might be pushed back, but a couple hours before bedtime, it's good to really try to limit your fluid. I had a patient a number of years ago who had a problem with urinating all night. And I found out every time he got up to go to the bathroom in the middle of the night, he drank a full glass of water. So no wonder he had to urinate again 2 hours later. So definitely overnight, if you feel like you've got some dry mouth, put some water in your mouth, kind of swish it around, spit it back out, or take small sips, but not drinking a lot of fluid overnight, especially. Next slide. So napping, the napping piece. So some people with Parkinson's, I find, do better getting less sleep at night and taking a regular nap. So in general, the party line is if you have trouble with sleeping overnight, you shouldn't be taking naps during the day. I have found, and I think many providers have found this, that in people with Parkinson's, often they do really well with a nap. And also that nap in the afternoon sometimes is this recharge. There's people who get what's called sleep benefit, and their Parkinson's symptoms actually get better with sleep. So I find for those people, oftentimes that nap is really helpful. In terms of length of nap, I think someone mentioned in the chat box, there's two kind of ways to go. And you can either do a short nap, which is in the 25 to, you can do a micro nap, which is just like sitting, closing your eyes for a moment, and then kind of get minutes and getting back to things. And that sometimes can be helpful. Then the short naps would be in the 25 to 30 minute generally. And this is when you're going to stay in those light phases of sleep. So you're going to get a little bit of rest, but you're not really going to get into deep sleep. If you want to take a longer nap, then oftentimes you want to do an hour and a half or 2 hours. So you really get into that deep phase of sleep and get through a full sleep cycle. People sometimes will set their alarms and nap and then wake up after 45 minutes or an hour, and they'll say, oh, I feel worse than when I laid down. And that's because you're waking up when you're in that deep phase of sleep. And then your body really wants to sleep more and kind of finish that cycle. And then, I think if you're doing that like 1.5, 2 hour nap, then you have to think you're going to cut back your hours at night. So you may be only sleeping 6 hours at night and doing a 2 hour nap and expect that's going to be the case. But like I said, I often find in Parkinson's that works better than trying to get the 8 hours at night. Make sure your room is quiet and a comfortable temperature and well ventilated. You want some flowing air is good. You don't want it to be too hot. You don't want it to be too cold. And consider your natural rhythm. I think one of the Parkinson's is a disease that tends to affect older people. A lot of times people are retired. If you have always been somebody who did great when you stayed up till 2 a.m., and that can work with your schedule now, and you can sleep from 2 a.m. to 10 a.m., go with that. If you're somebody who does really well getting up at 4 o'clock in the morning and going to bed at 8 o'clock at night, go with that. That's fine. If you can make that work with your schedule, I think that can really work. Oftentimes there's also people who did night shift all their career and now they're retired and they're trying to do a normal nightly sleep pattern and it doesn't work for them. So really think about what your natural rhythm is. And if your schedule allows you to take advantage of that, that's a good idea. And again, it doesn't matter exactly when you get that sleep as long as you're consistent with it. That seems to be the most important thing. Next slide. So other sleep hygiene pieces, if you can't fall asleep, you don't want to just stay in bed. So, if you're sitting there and you're just thinking about all these things you have going on and you're just worrying about it, then it's good to get out of bed, read for a few minutes, 15, 20 minutes, and then try to go back to sleep and just repeat that cycle. You don't want to do television. The light from television is very stimulating. Faces are quite stimulating. So oftentimes on television, we're seeing faces. There's these suspenseful, exciting things happening. Those aren't good things to have. Sometimes music is very helpful for people. And try to keep the sleep area dark. If light bothers you, use heavy curtains on the window. Even an eye mask can be helpful. And then a mindfulness practice can be helpful if you wake up overnight and can't fall back to sleep, or even as you're trying to initiate. And again, we'll do the body scan a little bit later. Next slide. I'm going to, before I talk about the medications, let me pull up the chat because I know there's been a few questions and I can look at these a little bit. It'll just take me a second. So siestas, I think I talked a little bit about that. So napping, like I said, can be helpful and kind of those two lengths, and then know that it might affect your sleep overnight. And then someone said that changing to Rytari has been a life-changing experience. And that also that insomnia in the COVID world, this new COVID world, has been really, really tough. And I agree. I myself was having issues with that at one point. And for me, what I was doing was my kids would finally fall asleep and then I would read the news, and the newspaper. And that was my time to do that. And probably not the best time to be doing that. So think about, when in your day you want to kind of focus on that. Because I think we have to read, we have to know what's going on, right? We don't want to just necessarily bury our heads in the sand. But then at a certain point in the evening, it's probably good to say, okay, I'm going to step away from that. I'm going to, watch a light movie. I'm going to read a light book. I'm going to do some stretching, something else to kind of move away from that. Okay, and then there's a question about a specific medication, and I'll talk with those just a little bit more. So this question is, what about a night owl who has to be up at 8 a.m. to take medications? That's a really good question. So you might want to switch around the timing of your medications. So, you know, a lot of people kind of know their time frame that they need to go 3 hours between doses, 4 hours, 5 hours between doses. And so you might just want to start from when you're awake. And again, if you can keep a consistent schedule, maybe your first dose won't be till 10 o'clock in the morning, but if you can schedule your doses to be regular throughout the day, that might work really well for you. If you're not sure about how to do the adjustment, I'd talk with your provider. The other thing I'll have some patients do is they'll be able to take their first dose and go back to sleep for a little bit. So if they have a bed partner or significant other who gets up earlier than them and kind of gets their first dose in, they fall back to sleep for a little bit and then get up. And when they get up, their medication's actually kicked in and they're kind of ready to start the ground running. Okay. So back to the medication. So I'm not going to go into these in depth, but there's a lot of medications out there. Benzodiazepines like clonazepam, sedating medications like trazodone, medications such as Ambien, Lunesta is another one in the hypnotic category, antipsychotics like Seroquel, quetiapine is another name for that one, and then things like Benadryl and herbals like melatonin. So, you know, most of these are good for sleep initiation. They're not good to keep you asleep, and all of them can have a significant side effect. So I'm not going to go into them more in detail here. I think, you know, if we can use lifestyle things to manage, that's probably better. Melatonin is one of the safer ones, probably. Things like Benadryl, probably best to avoid. We know that it can cause cognitive issues and probably not great long-term. Benadryl is also, it's called diphenhydramine is the other name. And it's also in all the like Advil PM, Tylenol PM, that's kind of the sedating medication there. So any of these you should talk with your individual provider about. And some of them are reasonable to use. But like I said, they all can have side effects. And that's the nice thing of lifestyle stuff. It's not as big of an issue. Next slide. So now moving on to talk about excessive daytime sleepiness. So trying to figure out how to get good sleep overnight, but then you may be feeling tired during the day, even when you do get reasonable sleep. And here again is that circadian rhythm. So the one that we went through. And like I said, you know, overnight that sleep urge in Parkinson's tends to be less. And then as the day goes on, that sleep urge tends to be higher. So oftentimes people with Parkinson's will start to get really sleepy kind of the early afternoon, early evening. So the circadian rhythm is a little disjointed here. And this may be where you do that short nap to kind of boost you so you can make it through that time and then cut back on your sleep a little bit at night. Next slide. So why do people feel sleepy during the day? So it can be related to the disease itself and things that go along with that. So we know people with Parkinson's are more likely to have insomnia at nights for many reasons. And so if you're not sleeping well at night, you're going to be more tired during the day. Depression can really contribute to a feeling of tiredness, fatigue, and that can be something to look at and make sure that that's appropriately being treated. And then there can just be fatigue itself with the disease. We know that people with Parkinson's often don't have as much energy, and the neurochemical changes that go on can relate to this and can also increase the risk of depression. So there's more depression in Parkinson's than other diseases with similar effects on health. Also, it can be related to the drug therapy. So many times the medication themselves that we use, the levodopa, the dopamine agonists, can make people feel sleepy. Antidepressants oftentimes can be sedating as well. They can kind of go either way. And then sometimes people are on other sedating medications. Next slide. So how do we treat excessive daytime sleepiness? So trying to work on all the good sleep stuff that we already talked about, trying to avoid sedating medications. So if you're taking something to help you sleep at night and then you're still finding that you're groggy in the morning, you probably want to try to cut back on that. And with the Parkinson's medication, sometimes using extended release versions, again, can be helpful, especially the dopamine agonist. I usually find people still need those twice a day, but that you can take those, one in the morning maybe and one at night, or even just try a dose at nighttime and get the benefits of it, but not as much of the fatigue that comes on with each dose. Dopamine agonists, so the ropinirole, pramipexole, tend to be more sedating than levodopa, so sometimes doing a switch out of those two. And then if there's sedating medications you're taking for other things, trying to switch those out and see if you can take something else instead, or just cut back on them. Next slide. So excessive daytime sleepiness, make sure that it is just sleepiness and not apathy or depression. These may need to be addressed with antidepressant medications, with therapy. Apathy, often kind of behavioral interventions are appropriate. So apathy is just kind of a lack of interest in things. I'll often describe it as people kind of just need a kick in the pants when they've got apathy. So they may be perfectly fine going out and doing stuff when someone else takes them along and says, hey, we're going out to lunch, and they're good. Not that we're doing that now, but we're going out for a walk, and they're okay, but they're not going to be the ones to have to get up and go to do that. So they might need just more encouragement to do things. Getting exposure to sunlight during the day. There is also some blue light therapy, which I'm not an expert on, so I didn't present here, but that's something also that can be an option potentially. But just getting regular exposure to sunlight when you have it available outside is good. And then exercise, again, not too close to bedtime, but during the day, getting out and getting moving is going to be helpful. Next slide. Caffeine may be appropriate at times. This is probably not something we want to use all the time, but there's times when this is a reasonable approach. Especially I've had some patients with driving issues. If they get a little bit tired and aren't having to do that a lot, caffeine might be a good choice. There's a medication called Provigil or modafinil, and that may sometimes be helpful. It's sometimes not covered by insurance, and the studies have been a little inconsistent in terms of showing the results, but that's something that may be worth trying too. It's not clear if if stimulants like Ritalin can be helpful, but that's another thing that's out there, but I rarely use that unless we're really desperate. Next slide. So after this talk, do you feel like you'd be more comfortable discussing your sleep-related concerns with your provider? Wow, that's great. 100% so far. Okay, there we go. I was going to say, was it rigged there? Because 100%, I never trusted if it says 100%, but looking like about 97%. So that's great. And again, there's not usually one easy answer. And now I think we'll move on to have Dr. Proulx talk a little bit about mindfulness and sleep, and then take us through a nice body scan.
Great. Thanks, Dr. Hiller. Again, hi, this is Jeff again. And Amie mentioned a couple times this body scan, and we're going to do this a relatively quick body scan, but I wanted to bring up a couple things in research and just in my personal experience. People have found this exercise to be very good for sleep, but also very good for pain management for a number of different reasons. But I really like this for sleep. Now, I want to emphasize that generally when we do any kind of mindfulness practice, we want to become more awake. We want to become more aware of what's going on. However, this does tend to be a practice where we can get very sleepy. So as we begin, I do want to encourage you to have the intention to remain awake and to remain aware of our different body parts as we go through. But all we're going to do is we can do this sitting up. Oftentimes a body scan, and you can find recordings for this in many different places. That UCSD, the University of California, San Diego site that we had posted in the beginning of this series, has a couple of very good body scans you can do. And they generally ask you to do it while you're lying down, but it's up to you. So I'd like you now, if you can, just to get into a nice position, a comfortable position in your chair with your feet flat on the ground and your hands on your lap or wherever you feel it's comfortable. But as usual, with a nice straight spine and a nice sense of exhibiting the sense of being awake, of being present, and being noble, and being dignified right in this moment, but relaxed, settling into our body. Become aware of your belly rising and falling with each in-breath. Keeping your attention on your belly rising and falling. And on the next out-breath, what I encourage you to do is to bring your attention all the way to the big toe on your left foot. First of all, noticing that the strength of where you want to place your attention in any moment is up to you. And now keeping that attention on the big toe of your left foot, noticing temperature, texture, and then becoming aware of all the toes on your left foot. Feeling where they touch the ground, or perhaps feeling in between the toes, and then feeling the top of your left foot and the bottom of your left foot, in your heel. And you don't have to move your body in order to get any kind of elicit a stimulus. If you don't feel any sensations, that's fine. Whatever you're noticing in this moment is absolutely fine, because it is what it is right now. Without judgment, bringing your awareness to your Achilles heel and the calf of your left leg. And feeling that place where your knee bends, behind your knee. And examining your entire kneecap. Noticing places where it may feel sore, or cool, or itchy. Whatever's happening in your kneecap right now. Noticing it, and then moving on to the thigh of your left leg. And the top of it, nice and long as it's sitting here stretched out. And the bottom of your thigh, perhaps where it meets the chair. And then breathing in as deep as you can, as though you're breathing from the top of your head all the way through your torso, down your leg and out the foot, your left foot. And then exhaling, breathing from your toes all the way back through your leg, all the way through your torso and out your breath. And at that same moment, letting go of your left leg and switching your attention to the big toe on your right foot. And the other toes on your right foot. And the ball of your right foot. And noticing on the bottom of your right foot, what part of the foot is touching the ground and what part is not. If you're wearing socks or shoes, what does it feel like on the bottom of your foot? The texture of the sock, or the support of the shoe, and into your heel. And then bringing your awareness up the calf of your right leg, and into your kneecap of your right leg. And feeling into your thigh in your right leg. And notice if you're forcing your attention or if any other part of your body is tense, let it go, let it be loose. Having this awareness with a sense of freedom and openness to the buttocks as you're sitting in this chair. Feeling the pressure on your chair, noticing if there's any temperature, if it's warm where you're sitting or cool. And then coming into your hips, both the right and left hip. And into your abdomen. And into the internal organs in your abdomen. See if you can feel your body at work, metabolizing, getting rid of waste. And then bringing your attention to your lower back, This is a place where we often tend to hold stress. And to the best that you can, just being able to just notice what's here without changing anything. And then following your spine one vertebrae at a time in your mind's eye, and examining the muscles in the rib cage as you rise up your back till you get to the upper back, feeling into your shoulder blades. Are your shoulder blades tense? Or are they loose and melting down your back? Feeling into your shoulders. Another place where we tend to hold stress. No matter what's here, just bringing your mind to that place, settling in, and just noticing what's here. And then noticing the biceps of both your left and right arm. And following down your arms to your elbows. Spending a moment here just inhabiting your elbows. A place that we rarely spend any time attending to unless we hit it or it's sore. And allowing your awareness to travel down your forearms to your wrists. Into the palm of both hands. And then examining from your thumbs to your index fingers to your ring fingers and so on. What's happening in your hands and your fingers right now? Noticing any pulsing or blood flowing. And also notice that there's an entire universe of stimuli going on in your fingers right now that we're rarely aware of when our mind's distracted with daily life. And then bringing our awareness back to our abdomen and up towards the chest cavity and the breastplate. And watching as your chest expands and rises and falls and collapses with each breath that comes in. Noting the elasticity of this part of our body as it can expand and contract and expand and contract, allowing us to take in vital breaths. And following that breath process up to our throat, in the back of our neck, in the back of our head at the base of our skull, and then following that around through our jaw. And noticing if our jaw is tight and clenched or loose. Into our mouth, in the bottom of our nose, and then the bridge of our nose. Into our eyeballs, and noticing if they're heavy in our eye sockets and tight, or if they're loose and laid back in the eye sockets, relaxed. Into our forehead. Is our forehead wrinkled and tight or soft and smooth across? And then bring our awareness to the very top of our head. The very top, there has to be a point that is the very peak of our body, maybe only the size of a pin. Allowing your awareness to just settle onto that one point, letting go of all other parts of your body, and settling into the top of your head. And just taking a moment to breathe in with a nice deep breath, exhaling and opening your eyes, and then just come to this, back to this present moment of non-body scanning. And we're open for any quick questions that you may have.
And we have one. Oh, go ahead.
Oh, there's a question. After this mindful practice, how do you feel? Few people are anxious about this, but generally relaxed and calm and a couple sleepy, that's to be expected. And just a quick thing is that I tend to do this before I go to bed. I find it helps me go to sleep. I do my best to try to stay through the whole recording when I'm listening to it, but it's oftentimes I can't. I'm one of those people who goes to sleep right away. So if you are practicing this and find that you go to sleep, don't get mad at yourself. It's very common to do. And it's also a good practice to do if you happen to wake up in the middle of the night. You can engage in a body scan. This is just a good strategy, but it's something that you're going to want to practice on a day-to-day basis, because when it comes time for you to use it, you want to know how to use it.
And I think we just have about 2 minutes before we have to wrap up. If anyone has a quick question, I think we answered a lot of them as we were going through. So hopefully that was helpful. And we'll have a couple more Mindfulness Mondays coming up. So could also potentially answer questions as we get there. This is one of my little ones, my little guy with his Goodnight Fire Engine book and PJs. Can Parkinson's and idiopathic neuropathy can't feel feet? Yeah, so if you've got neuropathy, managing the neuropathy with medications may be helpful to try with that. Sometimes people also put up these things on the bottom of the bed that keep the sheets off their feet, and they find that helpful too. Mirtazapine, where does that fit in things? So mirtazapine can be useful for mood and also can help with sleep. So sometimes you can use a medication to do more than one thing. So if you're thinking about managing, if you've got some symptom that you need to manage, also mention what your sleep is, because some are stimulating and some are going to be more sedating, and so you can take advantage of that. Well, thank you, everyone. Do you want to take over, Crista?
Yes, thank you, Dr. Hiller, Dr. Proulx, and thank you all for joining us today. I certainly feel relaxed after that body scan, and I will certainly be using that much more often as I lay my head on the pillow. Thank you both so much for giving us those tools to use. A couple of just some events that are coming up I wanted to make sure you all are aware of. This week we are having an expert on our Facebook Live page. You can find Parkinson's Foundation on Facebook, where we'll be having an expert talk about how to prepare for a telemedicine visit. So I know many of us are having to explore the telemedicine platform. And if you have any questions for the experts, you can find us on our Facebook page Wednesday at 12 p.m. On this Thursday, we're kicking off our new webinar series where we have partnered with AARP, and they will be addressing newly diagnosed and their care partner community. Again, that's this Thursday at 3 p.m. Eastern Standard. On this Friday, we have our Fitness Fridays. The focus this week will be stamina and cardio, so make sure you get that on your calendar. Get moving this Friday. And next week's Mindfulness Monday is Mindfulness Communication During Challenging Times. So be sure to register for next week's Mindfulness Monday. We'll be featuring Taylor Rush from the Cleveland Clinic out of Ohio. For any of these events that you might be interested in, you can visit parkinson.org/PD Health. We're also having our virtual moving day walk. How exciting! So on Saturday, May 9th, we are all going to be coming together virtually to walk for Parkinson's disease. So please join us in this day of movement celebrating our Parkinson's community is coming together. You can register and learn more and visit movingdaywalk.org. Again, that's Saturday, May 9th. And of course, our annual Care Partner Summit. This will be an online event on Saturday, May 16th from 12 p.m. to 3:30 p.m. Eastern Standard Time. You can join us and register parkinson.org/summit. So we have a ton of virtual events for you guys to stay connected, to have the resources and education that you need during this strange and unique time. And I would like to just thank you all for joining us today. If you're still with us, if you wouldn't mind coming on camera I'd like to invite you all to smile at your camera, start scrolling through the screen to see all the people that are joining us today, giving them a wave, saying hi. This is your Parkinson's community. This is what we're doing. We're coming together. We're figuring out this new Zoom platform, and we're staying connected during this strange and unique time. I'd love to give a huge thanks to our speakers, Dr. Hiller and Dr. Proulx. They have been with us from the kickoff of Mindfulness Monday, so I really sincerely appreciate your guys' collaboration and your efforts to bring us these tools, this discipline of mindfulness as we learn and navigate this strange and unique time of quarantine. A major applause to all of you who have joined us today. So major applause to you guys for joining us. And try using that body scan tonight for better sleep. So again, register for next Monday, Mindfulness Monday, Communication During Challenging Times, and I'll see you all right here next Monday. Thank you all for joining us. Bye-bye.